Hello, my name is Tony Taylorson from Cambridge University Health Partners, and I'd like to welcome you to the next episode of the Cambridge Biomedical Campus on a virtual tour series. We've had some of the best clinicians and researchers and academics coming along to explain their work, the challenges they face, from Cambridge University Health Partners, and I'd like to... sorry, bear with me, other bits and pieces are talking, sorry. So the challenges they face, their thoughts on what the future of the healthcare will look like. And today is no different as we welcome Professor David Rowitch, Head of Department of Pediatrics and Academic Lead for the Children's Hospital, to hear all about Cambridge Children's. In today's talk, David will be discussing how this innovative new hospital will integrate with physical and mental health care to benefit children and young people locally and globally. As usual, throughout today's talk, if you are watching through Zoom, you can ask questions at any time using the Q&A box, which we'll try to address at the end of the talk. We will do our best to include any comments made by those on YouTube Live, but please do not be too disappointed if yours is not included, as we often have a very chatty audience. And finally, to reassure you all, you won't be seen or heard throughout this event, but it will be recorded to be available on our website and CBC YouTube channel afterwards, and a link will be forwarded to you by email. So without any further delay, and hopefully no more weird sounds coming from a computer, let me hand over to David. Thank you.
Thanks very much, Tony. It's a pleasure to be able to present some ideas of the Cambridge Children's Hospital to you all today. And hopefully you'll see my slides coming up in just a second. So again, a pleasure to introduce Cambridge Children's Hospital, and wanted to frame this in terms of how we are looking for input from the community as we think about a hospital that can serve the region, but also develop bold new ideas for pediatric health that can impact children nationally or even globally. So the slide, Dream Hospital Ideas, this is part of our way of engaging with community, and I'll say that what this event is part of that. So I'm going to try to start with some big ideas, and some of these have come from history. Here's a quote from Frederick Douglass, an American former slave, who said in the 1800s, "It's easier to build strong children than repair broken men." I mean, for a very different time and a very different scenario, but actually a vision for pediatric health extending into adulthood and having long-term impact. And that's an idea that we've kept in mind. The problems in healthcare today, thinking not only about the UK, but also globally, and how our healthcare system is addressing the concerns that we have about long-term health. Our approach to healthcare for many nations isn't working. You can tell I'm from the United States, where disparities in healthcare access are a major issue that limit overall health outcomes, and leading to the US having relatively poor health outcomes. How can we do better? Even the world's best systems use approaches that are dysfunctional, expensive, and antiquated. And the advances that we make in research across the life sciences aren't yet benefiting children of today and the adults that they become. We know that brain and mental health problems affect all ages. But, and this might be surprising, 3/4 of mental health conditions have their origins in children and young people. So this starts to argue for why we must have better systems for detecting the origins of these disorders in order to have a better long-term impact. This also applies to genetic illnesses, which also appear mainly in pediatrics early in the life course. And here are some of the really devastating numbers for genetic diseases, which affect over 200 million children worldwide. By rare diseases, these mean diseases that are caused by gene mutations. They can account for up to 1/3 of hospital admissions in pediatrics. And if we could take a condition like cerebral palsy, 19 million people worldwide are affected, and we're now starting to recognize that many of these are caused by genetic conditions. So what if we're tackling this the wrong way? What if we could predict physical and mental health disorders rather than waiting for symptoms to appear? What if we could begin a new type of data set across an entire country using state-of-the-art genomics to individualize treatments from birth? and gather data, building a living network of human genomic knowledge that constantly updates itself in real time. If we did this, we could begin to understand how nature and nurture interact to affect health of the next generation. We could begin to better predict, not just react to diseases when they appear. And we'd shift the paradigm from eventual diagnosis of a condition in adults to true early detection and proactive prevention, interventions beginning with children. And we change and save and improve millions of lives. So this is our concept, this is our big idea. And why is the UK ideally suited to test and show the benefits of this approach? Well, we have the National Health Service, which is a system that covers 100% of the population. The NHS is the first national health system in the world to provide pediatric whole genome sequencing. And we can work at scale across the UK, where we can build regional and then national cohorts. We can cross-link the health record to education and other outcomes measures to really understand better how genomics or the impact of the environment can affect health across the life course. And the UK is already a key center for genomic diagnosis and research, where sequencing can now be done in a matter of days. And I'll show you some examples of that in a second. It's a major government priority to now bring genomic medicine for rare diseases in pediatrics, for cancer, and for other conditions like heart disease. So this investment the government has made is something that we can take advantage of to make advances. And we can prove things in the UK that then could be scaled from Cambridge nationally, but also to health systems around the world. Now, why Cambridge? Well, when it comes to genomics, we have an extraordinary track record of discovery. And this, the photos show some of the key players who have made discoveries, breakthroughs in understanding the structure of DNA, but also at the implementation phase, how we can make whole genome sequencing really practicable as a diagnostic test. And many of you will be familiar with some of the faces and names on this slide, but there's a terrific track record of discovery right in our backyard of Cambridgeshire. And I think the next slide is now going to sort of give you a more of a view of how this affects patient care at the bedside, work that I did with colleague Lucy Raymond, who's a geneticist. So this next slide will show a video, a Fergus Walsh piece that appeared in the BBC in 2019.
This is life at its most vulnerable, made even more perilous when the cause of a baby's sickness is unknown. In some cases, it can take months or even years to get a diagnosis, but that is set to change because of genome sequencing. What are you trying to do to me? Millie May and her parents, Claire and Chris, each had their genome, their entire genetic code, sequenced to try to discover why she was having life-threatening seizures. The results showed Millie May has a rare form of epilepsy caused by a single gene error, not inherited from her parents. It led to immediate improvements in her care.
Since we've had the diagnosis, it's been a lot better. We had to change one of her medications due to the fact that the one that she was on was obviously aggravating the type of epilepsy that she has. We saw a big difference as soon as that change was made.
It's priceless. That one test result obviously allowed us to put all of the correct people in place and make the best for her.
Sequencing the billions of letters of DNA code that make up a genome used to be hugely expensive. Now it costs less than £1,000. Scientists in Cambridge analysed the genomes of 350 children in intensive care, comparing it to the DNA of their parents. They found 1 in 4 children had a genetic disorder and were able to give the diagnosis in 2 weeks. This study shows conclusively that whole genome sequencing is of real benefit to patients, speeding up diagnosis and helping to find the right treatment. From next year, throughout England, the NHS will offer whole genome testing to all babies and children where the cause of their illness is unknown, the first national health service in the world to do so.
So that video gives you a sense of the impact both to families and also how a study in Cambridge has now led to a national service for whole genome sequencing being available for babies in neonatal ICU, pediatric ICU, and those that are seriously ill. But we also want to bring, new ideas when it comes to the understanding of physical and mental health and how we can start to treat these in a more integrated fashion. And to introduce this topic, I have another video clip from Professor Ed Bullmore from the Department of Psychiatry.
Today, the world is facing a crisis in the mental health of young people. Depression, anxiety, addiction, psychosis, self-harming, and suicidal behaviors are all increasingly common among children, adolescents, and young adults. Millions of young lives will be knocked off course by these much feared, still stigmatized disorders. And the old ways of understanding and treating mental illness are clearly not working. Otherwise, the World Health Organization wouldn't be telling us that mental illness is on track to be the biggest single cause of disability by the end of this decade.
What can we do about the global challenge of young people's mental health? Our answer, perhaps surprisingly, is that we can tackle the challenge more successfully by making it bigger. We think we can do a better job for mental health if we also think about physical health and social context at the same time and in the same place. We can bring together a more integrated vision of mental health by breaking through some of the barriers that now separate body from mind, child from adult, home from hospital. First, and most importantly, we need to reunite the body and the mind. Mental and physical health are currently treated very differently by different doctors in different hospitals. This split between mind and body, hardwired into the organization of the vast majority of Western healthcare systems, is scientifically out of date and out of alignment with the very commonly lived experience of mental and physical health symptoms combined.
So a perspective from Professor Bullmore, who I think will also be giving a talk in this series, and you'll hear more from him later. We've taken those ideas, to heart and tried to think differently about how we can deliver healthcare that can make a difference, considering the crisis in mental health today. So why Cambridge? Well, we have foundations and intellectual resources. We're an epicenter of genomic expertise. We feel we can catalyze integrated care of physical and mental health conditions for children and young people. And through the NHS, we can connect patients to gene and individualized therapies with equity of access. So here's what we think the impact of our model will be. We think that we can come up with the neonatal screen of the future. Let's say in 20 years, we'll have more experience with understanding how genomics can help us diagnose serious genetic problems earlier and make better decisions, start personalized therapy sooner, not later. We can couple the genetic findings to long-term outcomes to be much better at predicting risk from the start, making better decisions for patients. We can work at scale, and we can create a database that can constantly be updated. We can incorporate both physical and mental health outcomes to be able to think holistically about preventive interventions of these serious diseases. And again, the NHS will help us ensure that every child will have equity of access to the benefits of this new paradigm in healthcare. So that's our model. But to do it well, we have to give it a home. And that's what Cambridge Children's Hospital is meant to do. It's meant to deliver on these ideas. And I'll tell you our plan for how we aim to do so. This is a hospital that has 3 unique selling points. The image shows some of the design team's submissions to the planning committee, which is currently evaluating the hospital, which will be located on the Addenbrooke's Biocampus. Cambridge Children's is unique. It's a collaborative endeavor between the NHS and the University of Cambridge, and it has 3 USPs. The first is, let's see if I can get there it is, the whole child, a fully integrated physical and mental health care approach. The whole life, which will be researched to understand the origins of disease, supporting earlier detection, intervention, and prevention. and then how we can support the whole community as a regional hub that has also wider impact. Our design principles are highlighted on this slide. This also shows an image of maybe as you're coming into the hospital, some of the interactive spaces. There will be a school in the hospital, and that would be located sort of here. There'll be research, there'll be clinical work, and then lots of garden and family spaces. We designed this hospital to be as small as it possibly can be to support the region. We don't want to have to transport children out of region to London or Leicester or Liverpool or Bristol when we don't have to. When we feel we should care for the sickest children in our own region. And we're the only region in NHS England without a children's hospital to do so. So we think we have a critical mission to support healthcare within the East of England and East Midlands. We will have embedded research. We will be co-creating this with children and families. We'll be creating outdoor spaces within the hospital, and we will be creating the greenest hospital in the NHS with new standards for net zero. So our USPs, the whole child. This will be a pioneering integration of physical and mental health care. It is globally leading. This is not a care plan that is practiced in the United States or really anywhere else in the UK, with a full integration of physical and mental health care for better outcomes. And you can imagine a child with an eating disorder who currently might be treated in one facility by a psychiatrist or another facility by a gastroenterologist or a pediatrician. That is not optimal. Wouldn't it be better to have those teams working together on a daily basis, caring for that child so they have the full spectrum of expertise? Or children with chronic diseases or cancer, who we know are vulnerable for mental health risks like anxiety and depression. Wouldn't it be better to have a team with psychological support to be able to preempt, address those questions or those problems as they emerge? We think that psychologically informed care will be a big magnet for staff coming to Cambridge who will be able to take care of their patients better. And also, as you begin to understand what might be symptoms of mental health, that will lead to early detection so that a pediatrician like myself might be much better at recognizing depression before it gets too entrenched. Also, research so that we can find how our ways of working can be reported, evidenced, and then convince others that this could be a model that could be useful across the NHS, as well as how we can research the biological underpinnings of mental illnesses, as Professor Bullmore highlighted in his video. When we talk about integration, we're talking about a purpose-built ward that will have, the one hand, medical and pediatrics, and on the other, a psychiatric provision. So every floor will have physical and mental health with collaborative spaces and shared spaces within. And what we imagine is this pink zone is going to expand, because as we start to practice this model together, we're going to see that many more of our patients will be eligible for this integrated care model. Again, the first hospital in the world that's been designed to integrate physical and mental health as opposed to siloing the two endeavors. The whole life refers to our research approach, as I've mentioned before, thinking of a baby as almost the adult they'll become. How would that change our care? And the University of Cambridge is now planning a research institute to be located within the hospital that will allow interesting mixing of investigators with patients and with clinicians. And we think some great and inspiring dialogue will come just from those sort of serendipitous interactions. Our research institute has a strategy to address leading causes of death and disability affecting children and young people in the UK and around the world. And the 6 centers are highlighted here. I won't spend a lot of time on them, but maybe I will give a couple of examples of where we think these are very important. I've mentioned genomic medicine. I've touched on the mental health crisis, and I'll try to give a couple of other examples. And maybe if there are questions about some of these centers and why we've made these choices, we can go into them in more detail. But as someone who's involved in the Cambridge landscape, I know that we can offer something unique and important that will not only increase our understanding of disease, but also lead to new, NHS provision. And that's where this institute is really trying to focus, is how can it add value to the NHS? Where is research value added? How does it increase or improve options for our patients? It's located on the Cambridge Biomedical Campus, and many of you will be familiar with all the very unusual assets here, you know, between the laboratory of molecular biology, industry like AstraZeneca and Abcam, the Royal Papworth Hospital. What's highlighted here is the location of the Children's Hospital in the little cartoon with the signature 1, and then a couple of institutes around the campus, the Wellcome MRC Cambridge Stem Cell Institute, where I have my laboratory, and the Cambridge Institute for Medical Research. And the point here is that this Children's Hospital is going to be in a great position to interact with the assets across the campus. And that would include academic institutions and industry. I wanted to give an example from work that I do. And one of the patients that I would take care of is represented by little Rocco, who you can see has got some severe impairments. He's in a special wheelchair. You can also see that he has a tracheostomy, which means difficulty breathing. And he has a condition that's called Pelizaeus-Merzbacher disease. It's one of these rare and serious genetic conditions. And partially in response to a request from his parents, colleagues of mine and I were able to use laboratory techniques to create patient models of disease, so-called patient-specific induced pluripotent stem cells, or iPS cells, from which we can model the cells in the brain that have gone wrong in Rocco, use that in a, I think, positive way to look for drugs or gene therapies that could help his own cells work better, and then try to then complete the loop, returning to the patient. And I'm pleased to say that these studies identified a drug called deferoprone, which did improve the outcome of Pelizaeus-Merzbacher disease brain cells, and that Rocco is now on that medication. And this could be a kind of a foretaste of how we'll be treating patients with rare disorders in the future, coming up with specific types of therapies that might work for them, understanding how one patient like Rocco could actually be representative of a whole cadre of patients who will now benefit from the integration of research with a clinical perspective. And that's why I think the Cambridge Biomedical Campus has tremendous opportunities. We can really think about this now systematically as an ecosystem. We can take advantage of the fact that the NHS now is providing improved diagnosis through genomic sequencing. We can link it to the university, like the example I just showed you, and other university partners. We can then use that for precision medicine. And by that, we mean medicine that's tailored to the particular issues of that person. Now, I showed you a rare disease, which may be required a specific medicine, but for others of us, it may be the dosage of the medicine is going to be tailored because we're more sensitive, so we can avoid side effects if we just come up with the right dosages. So this idea of precision medicine is really feasible and could very likely start to have impact for rare and more common disorders. And then to kind of complete that course, we measure outcomes. So anything that we're doing, we're really taking advantage of our data resources to be able to be sure that it helped that child. Did they do better in school, or is there a problem? You know, are there other points in the life course where we can intervene? And that's where measuring outcomes is so very important. So here are some of the assets of this model that we're starting to now find a lot of interest from partners nationally and around the world. Creating a national database for early rare disease patient ascertainment, linking those to long-term outcomes to become better at predicting health risk, you know, with the outcome data. Finding the interest from industry, creating international partnerships, and then also digital networks. And this slide just highlights some of the partners who we are now discussing either academic collaborations with or even opportunities for industry to be involved. And this would just be the beginning. And why I find this to be a very kind of positive direction is that we really have very few medicines that are designed for children. There's a lot of attention on cancer, dementia, and diabetes and diseases of adults, cardiovascular, but there's been a sort of unmet need when it comes to thinking about new therapies for children. Of course, they have some very serious diseases, often fatal, and I welcome the attention and new investment from the research realm to be able to make some some differences. This is a bit even more detailed about our data strategy, but it is a new National Institute for Health research bioresource component for children and young people. This again recognizes, I think, the need and the opportunity in children to be able to now recruit children from across the country with diversity, take advantage of genomics and other of the sort of sophisticated tests that can help in maybe predicting disease, incorporating data linkages to come up with proxies for long-term outcomes with the view that this can provide benefit. And that's a key aspect. We're not just doing this for research and just sort of writing a paper. It really has to show, in our view, how we can affect the health system and shift from reactive to prevention of disease. Understanding disease origins so that we can really understand the influences of nature or nurture, and then how we can use that to program in direct benefits to subjects through diagnosis, medical advice, and new treatments, and continuous improvement, because the data is always changing and our understanding of the genome is improving. That has to be incorporated in real time. And that's our vision for the Children and Young People's Bioresource. Reaching out across the university also brings in also tremendous potential. And this lists the different departments in the University of Cambridge that have shown interest. And now we think Cambridge Children's can be a catalyst for a lot of interdisciplinary thinking. Just one example from working with engineering is the closed loop system or artificial pancreas that's been designed by Professor Roman Hovorka, who's an engineer. And many of you may be familiar with this, that this, for a patient with brittle diabetes who might have to test and inject themselves with multiple doses per day, this makes their life a lot easier because it's a continuous glucose monitor that then talks to an insulin pump, and every 15 minutes is adjusting the insulin dose. So whether they're sleeping, awake, in sports or other activities, it's constantly adjusting to maintain better glucose control. Roman has now rolled this out into an app which is available in the NHS. So this now has gone from a discovery in Cambridge to now a program that is available to NHS patients. Little bubble 3 shows that patients really like it, that it's improving their quality of life. There's a very positive response to this in terms of how their life has been made better. And then bubble 4 shows Julia Fuchs, one of our PhD students, who's now taking this information from the UK to a larger study in Europe. And it's just an example of how our research can have that kind of national and international impact that I described. Well, I'm going to start to wrap up in the next few slides, but do want to mention the whole community. Again, this is the only region in NHS England without a specialist children's hospital. We will support care closer to home, working with regional partners to keep children out of hospital where possible and manage them in the community. We don't want kids coming from Great Yarmouth to Cambridge unless they have to. But if they do have to be admitted to ITU, if they do need surgery, we also don't want them to go out of region because it's so much more difficult for families. And we'll leverage telehealth technologies to go beyond our walls to achieve these aims. And you'll see a couple of patients from around our region that are treated here currently in Cambridge. We are taking input from children and young people. We have a children's network of 500 people who are feeding into the hospital their ideas for what they want this hospital to become. We are interacting with politicians. Here's a visit from Bim Affolemi, who also has shown great interest in the hospital, and we can mention many other MPs from around the region. I think there's a lot of excitement from the community, from politicians, from other trusts and pediatric groups for the new ideas that Cambridge Children's Hospital will support. So to wrap up, it's a hospital, but it's more than a hospital. It makes promises. We promise to pioneer the whole child approach, the first hospital of its kind, purpose-built to integrate physical and mental health care, research to understand the early origins of disease, personalizing interventions to treat or even prevent illness, digitally connect to the region, to support providing care as close to home as possible. And of course, we will train the next generation of clinical and academic leaders. These will be the people that will replace me, bringing brilliant new ideas to keep our hospital vital and continuing to contribute. So finally, I'm going to wrap up with a video that Mr. Stephen Fry very kindly narrated for us that again, I think describes the vision.
This is the very first of its kind. A new approach to healthcare. A new type of children's hospital. A hospital built from scratch, which understands the whole child, drawing on research into mind and body to treat mental and physical health together. Seeing a person, not just a patient, taking care of them, not just their illness. Why should it stop a child playing, laughing? Why should it stop them staying with their friends and family? This is care that goes beyond hospital walls, stretching further into the community, closer to their favorite spot, to their front door. It's treatment that understands the child and the adult they'll become. This is a whole new way of thinking. Genomic research that personalizes medicine, which will help young people feel better now and long into the future. A beacon of biomedical expertise in the heart of Cambridge that will transform how we treat illnesses in our region and positively impact children's healthcare the world over. Cambridge Children's Hospital. This is a whole new way.
Okay, well, I can't top Stephen Fry. The Whole New Way is also the name of our £100 million campaign for the Cambridge Children's Hospital. Where are we at? We have in a timeline that has us opening the hospital in 25-26. This shows some of the phases along the way, but most recently applying for planning permission in 2021. Our campaign launched in 2021 and some of the milestones ahead. I'd like to end here and thank you very much for your attention. I look forward to your questions.
Great, thank you ever so much, David. Fascinating talk and insight into what the future actually holds, which is amazing. So we've had a few questions in the Q&A box, and if anyone has any other questions as we go forward, please let us know. So the first one is, how much genomic information discovered at childhood regarding the chances of getting certain diseases throughout life would you tell the parents of a child, and where would you draw the line regarding the potential impact that could have on their or their child's life's choices?
Yeah, that's an excellent question. I want to sort of, again, maybe rephrase how we have structured our genomic studies. You'll notice that what we did is we focused on children in ITU. We focus on children who have epilepsy or have serious conditions. And the reason that we've done that is we're really using this as a diagnostic test as opposed to a screen. And I think the question refers to, what if we had whole genome sequencing done at birth, and we have all of the information that could be predictive of health risks across the life course? How are we going to manage that? I think that's a question that will require decades of research to answer. We need to think about this responsibly. Our approach in Cambridge Children's is going to be much more on the acute needs and diagnosis. So I think arguably other groups will be tackling those questions. But what we are also doing, even with our patient cohorts, now we've done whole genome sequencing in over 500 families, and now one of our team is doing her PhD in psychology to look at the psychosocial impact of having had a genetic diagnosis on those families. We continue to stay in touch with them. We're continuing to support them because the question is such a good one. Even when it seems like an obvious place to apply genome sequencing, we still have to think about the psychosocial impact and have we really done something that has benefited families, and looking back, would they agree? But then, going forward, the field is going to need to start to, address these questions. Now, very simply, what I would say is the better we are at predicting, the better we are at advising. Right now, when you get a genetic test back, you get lots of, statistical risk. It's not very reliable. So you can end up causing a lot of sort of angst without necessarily having a good reason to do so. The number of genetic findings that are definitive are small. So I do think that we need to be very strategic in the way that we organize our genetic studies. We constantly think of direct benefits. And if we can't answer the question that it's going to cause a direct benefit, personally, I would not be supportive of going forward.
Thank you. You mentioned that there is no children's hospital in the east of England. And if you were to ask anyone in the street, do you know of a children's hospital? I'm sure the vast majority would say, oh, we've heard about Great Ormond Street, or Great Ormond Street is great things. So I wasn't really aware of any of the children's hospitals around the UK. So is there anywhere in this country or across the world which you're using as a model for what you think that the Cambridge Children's will look like? Or is what you're planning something just completely different from anything that's out there already?
It's a great question, Tony. So, I mean, Great Ormond Street is a great hospital. It's really a national referral center for children with super specialized problems. And we, of course, will refer children to Great Ormond Street, when that is necessary. Cambridge Children's wants to be more of a regional hospital. So we have a very different approach. So we really want to be integrated with the community, and that's where we think diseases first present. We think there's an opportunity to do diagnosis much earlier if we can establish a system here in the east of England. If I think of a hospital that's a good model for us, it's Evelina, which really does it's the regional hospital for South Thames. And I think they're very well networked and connected. They have outstanding CQC, and we've taken a lot of advice from them. From a research standpoint, I think Boston Children's is our model. That's I think one of the best research hospitals in the world. I may be biased because I'm American, because I trained there. But I do think if we can create our research strategy in Cambridge in such a way that Boston Children's Hospital throws up its hands and says, we couldn't do that here. We couldn't do this in Boston. You can only do it in Cambridge. And the elements that I described today pass that test because of the NHS, because of the provision of whole genome sequencing, and because of the national records that we can link to get, examples of outcome. That's not possible in the United States or many parts of the world. So we have a unique strategy. So we are constantly testing the field to sort of see how we can maintain a sort of, I think, vitality. But again, different than Great Ormond Street, and I hope complementary, because we'll be much more of a regional model.
No, that's great. So one of the questions that's come through in the chat is, I have a question regarding whole genome sequencing. Sometimes, if I could say it, some scientists argue that the initiative is designed to create a valuable health data set for the genomics industry, rather than an effective way of improving the diagnosis of rare diseases. They feel that if primary objective were improving newborn screening, there would be alternative, more targeted tests that would be cheaper and potentially more reliable. Do you have a perspective on this?
I do, Tony. I mean, I think I agree with the implication of that question. If you're very good at American accents, you can tell I'm from California, which is the state in the United States that offers, I think, 67 tests in their newborn screening. I think it offers more than any other country or any other state in the US. But in each case, there's an action associated with that test. And I think that is probably the best rationale for a newborn screen is, we need to know this information about, let's say, a thyroid hormone deficiency or PKU, because we need to act on it right away. And so I accept that point. Now, whole genome sequencing is being proposed as an alternative to, say, more classic newborn screens, and we're not there yet. We do not have the knowledge base. Whole genome sequencing is not reliable enough. It really is a research question. If it can be done responsibly, then I think, it's a question that does need to be answered. And I do think in about 20 years, we'll have that information to be able to say it will be the newborn screen. How will that benefit patients? Well, I've given you some examples, but they've really been targeted much more to the seriously ill children who sort of needed a diagnosis. I think there is around the world, when I speak about genetics, lots of sort of suspicion about how the information could be misused. Could it be used to potentially deny people care if they're in a private insurance health system? I think all of those concerns are reasonable. I think they need to be incorporated in any program that is going to responsibly investigate whole genome sequencing as a screen. And again, I want to make a big distinction between a screening test, which you might apply across the population, or a diagnostic test, which you're applying to an intensively ill child. We have tried to be very disciplined that our studies in Cambridge are directed when we think that there's going to be a benefit to that child as a test. Just to give an example, our studies now that are going into publication, when we have a child coming to the Child Development Center, which is our regional neurology center based in Cambridge, but actually networked throughout the region. So this is a child who has a pediatric neurology problem and they're going to a specialist. And the astounding result is that 1 in 2 of them have a genetic condition. So what we're starting to understand is, in certain clinical scenarios or with certain types of pediatric problems, whole genome sequencing must be available to them because the diagnostic return rate is so high. And that's how we're structuring our studies here, acknowledging, though, the concerns in the question. And I tend to agree that they need to be very carefully considered.
Okay, thank you. You mentioned in your presentation about that there wasn't, I don't think it's quite the way you phrased it, but there wasn't the focus on children's medicine as compared to adult medicine. Do you think there's any particular reason for that, given, is there anything to do with the kind of the size of the cohort you're working with, the difficulties of treating disease, or is it, and I hate to monetarize it, but there are more older people who pharmaceutical or medical companies would be more focused on? What are the challenges that are involved in that?
Well, I think probably we need to ask pharma that question. I know a lot of parents do ask that question, especially parents who have children with these rare genetic diseases. And you'll hear answers sort of as you suggested. The market is in the big adult conditions. Now again, that assumes a model where we are reacting to heart disease. We haven't really prevented it from occurring. We have taken this reactive approach specifies, you just go for the market and then the highest volume of drugs that will be consumed. A new approach is to sort of think about, value-based medicine, which is, we can do an intervention and it has a 10-year delay in the onset of diabetes. Can that be monetized? Well, in the NHS it can, or in the UK it can, because it's socialized healthcare. So if it's better care and it's cheaper to intervene earlier, that works here. And I think, around the world, the logic of that is very hard to argue with. But that perspective has not translated to big pharma. Even some of the biggest name companies that you think of based in the UK and Europe do not have a pediatric program. Period. The lack of interest is really striking. You may be seeing some changes now as some of these concepts that I've highlighted today come into the new thinking. Pharma may be starting to get, more interested. I would welcome that, but unfortunately, I can't say that it's represented currently.
Okay, thank you. One of the questions that's come in, we covered a little bit about they mentioned about the Great Ormond Street, but they also said, will the hospital have a clinical trials unit?
Oh, that's a great question. So, we currently in Cambridge have the clinical research facility, and that is for ambulatory patients with metabolic disorders, asthma, and we're also performing gene therapies there. We have enrolled prior to COVID almost 1,000 children per year in our clinical trials unit that already exists. We have a regional network in the east of England. It's also designed to recruit children from NICU. And so these studies are already happening. In the Children's Hospital, we don't want to undercut, we want to add to that work by looking at what are the specialist patients that will be coming in. So we'll be thinking about our inpatient mental health as being new opportunities for research, research that might go on in theater or in ITU, and that will be where Children's Hospital will add. So absolutely. I didn't obviously go through the whole plans of the hospital. You'd see little landing points for the researchers doing clinical research, like hotel spaces for them to work, to consent families, and so on, to be to be able to support a much broader research component.
Thank you. Well, slightly linked to that is that someone's asked about the physical nature of the hospital. They said, how will the structure and design of the hospital enable the child and her or his family to feel comfortable on visiting the hospital, especially from the very first moment of arrival, rather than feeling scared and literally feeling they were experimented on? As I'm sure any parent would be looking to care about their child and the nerves they must have when they're walking through the door.
Yeah, of course. I mean, it's very kind of scary place, and so how we want to be able to address that is, again, we're sort of using our University of Cambridge assets to help us. So one of our advisors, Paul Ramchandani, who's the Lego professor of play, who's also helping design a hospital in Copenhagen to have a playful atmosphere. And we think that there's a role for having an environment that kind of, changes your mood through the behavior of people and also the physical, look of the hospital, to be a bit disarming and to make it feel that much more comfortable. And children respond to cues that are very different than adults, and they can be programmed into the design. So part of that's happened. Also, we need to think about families that are going through very rough times because their child is very ill. So will there be quiet spaces for families to reflect? Will we have, appropriate pastoral care? And that, of course, needs to respect, a wide range of sort of cultural needs. We do have plans for green spaces, gardens within the hospital, and some of these will be quiet, more meditative spaces, when people just need a break. And so those aspects have gone into our planning and design, but we also do welcome ideas. And so I think through this webinar, let's say open invitation, and our website is actually asking for input. So we really are at a stage where we're looking for other ideas that might address and help better support families.
No, that's really, in terms of what children and families, because you mentioned that you've got the big network of people who've already been involved in designing the building and the services with the children and the families in mind. What are kind of some of the ideas that they've come forward with so far that you kind of thought, actually, why didn't we think of this? What have they brought to the table?
Well, I think some might not surprise you. I think young people are very concerned about the climate crisis, and so they're very keen on the green design. I think they also want to make sure that they have access to their devices and have lots of, ability to kind of maintain their connections with their friends. We've thought also about the importance of school. I hadn't really spoken about this, but there will be school provision throughout the hospital. And we're really going to try to either improve or keep people on track, when they're in the hospital. It shouldn't mean that they're unable to take their GCSEs or A-levels. We'll be able to support them through that. And then there's some surprising, so I think one suggestion was that we had a little farm with animals, in the hospital. Now we didn't quite do that because we didn't think it was hygienic enough, but we had some really creative ideas. Could I just come back to one point there, Tony? Because I think the question about how difficult it is for families to come into a hospital scenario, it will be so much better than our current provision in Addenbrooke's, which is our ward D2 and C2, where we do have rooms with, multiple children in one room with a curtain for privacy. That's extremely difficult, especially for adolescents who have to stay for long periods of time. You could just imagine how stressful that is for families who may not have even a place to stay with their child. That will be solved with the new hospital. We will have, ability to house families, privacy, and it will be, so much better and so much easier on families than currently what Addenbrooke's can offer.
Yeah, from all the things I've ever experienced within the hospitals, the dedicated work of all the staff who are involved, a simple bit of curtain doesn't give you any privacy or confidentiality or feeling that you are, that'd be a fantastic thing for people moving forward. I suppose linked to that, you mentioned, someone's asked the question about will there be space for families to be accommodated whilst their children are staying in the hospital so that they can remain close?
Yeah, the plan is to be able to accommodate families within the hospital. As I mentioned, the majority of rooms will be single patient rooms that will have a bed for one family member. There also is current provision through Chestnut House, Sick Children's Trust, And we are now speaking to other charities to be able to provide further housing for families that would be located at least on the biocampus, if not within the hospital. We sort of prioritize who would be in the hospital based on, the sort of acute situations. You can imagine, again, where it might be minutes or hours where a critical event could be happening, and those are the families that would really need to be close by. And we are definitely keeping families in mind and looking also for support as part of our fundraising campaign. That would include those that have an interest in provision for families, or even, think about bereavement and some of the communication of difficult news. What's the environment that will support that? And of course, you can imagine there is some science and there is some just sort of, planning that we want to do very carefully to support these sort of extreme situations. These are also ways that people could actually contribute to our fundraising campaign to make bereavement provision, as humane and as comfortable for families going through probably one of the worst experiences of their life.
Yes, that makes complete sense. You mentioned Chestnut House, and so someone's also asked the question about how does Acorn House fit into plans for looking after families who live a distance from Cambridge. But I suppose that also links into one of the questions I had, was that you mentioned about how important of managing treatment in the community, and how does that actually work? Because one example that someone could say, if your child is ill, you want them to be in the hospital for the best care. But how do you tell people actually sometimes the best care is in your own home? How do those conversations work?
Well, we have to be connected. And we have to have a good relationship with the East of England, pediatric services. I think I've seen some very positive movement in the last 5 years with the dialogue. Now we are thinking at one level, if you need specialist care, we're networking that. So that's now available. Pediatric neurology or pediatric cancer care is available in Norwich or Colchester. We have a networked approach. In response to requests from the region, we now have a pediatric retrieval service. So you'll start to see ambulances called Pender. And that means that we'll get a call in Cambridge about a child who might need to be admitted to hospital. But that's an opportunity for us to de-escalate care right at the hospital. So let's say they are in Great Yarmouth or Nottingham. Can we better support the patient, where they are, so that they don't need transport? Where's the best bed for that child to go? If they're in Great Yarmouth, it's probably Norwich. It's not Cambridge. We're not that. So Pander is really supporting and looking at a much more logical provision of the beds that we have available, depending on the acute needs of that child. And then, as you mentioned, sometimes the best care is at home. And so we can have, through visiting nurses, even very complex patients who may be on, let's say, IV nutrition because they're unable to take food by mouth. They could be managed in the community. And even when we think about hospice care, it's a very poignant example of how, many families would say if their child, unfortunately, has a terminal condition, they would rather that child were at home. How can we support that? And I won't go into examples because they're confidential, sort of. But imagine a medical team accompanying a child to their home, even a child who's on life support, to allow for that family to have an experience of end-of-life care that really is the most supportive for them, and we support that. So our commitment is really. It goes beyond digital. Yeah. It's just beyond telehealth, although we're doing a lot more of that, and COVID actually is making that.
That was one of the questions I was going to ask. Was how has the learnings of how medical care has been transformed in a way through COVID impacting on the way that you're thinking the hospital will work?
Yeah, no, it is transformative actually. So it is there is a little bit of silver lining to COVID. And that means, it's easier for families sometimes to have a video versus coming in and parking and all of the hassle. We think that there's also a lot more potential for us to be able to use our specialists in Cambridge to then support, physicians, pediatricians, or GPs around the region better. That would be part of our ambition. We are also thinking about specific partnerships. And again, it's one of these areas where if there is a trust like ESNEFT, which is the one based in Colchester, or Norfolk and Norwich University Hospital Foundation Trust, or others, we're sort of open for partnership. We're creating, collaborative consultant posts. That's helpful for building bridges, but we will really want to think about these specific ways that we can come up with more networked working. I can't say that we have a fully evolved plan. We are working with consultants now to develop that, but I know there's a lot more. There's a lot more to do, and I would say that in the next 5 years we probably be using digital support to help deliver that. It's a tremendous opportunity.
One of the last questions that's in the Q&A box, and sorry if I mispronounce this, but the question is, do you have any resources related to Friedreich's ataxia? I think so. And how to slow deterioration. Was that a very specific question? So sorry.
It is, and it really, I think it would probably speak to a research program in Friedreich's ataxia, which we currently do not have here. But coincidentally, it's going to be a conversation that I'll be having with colleagues in America next week. So there may be some updates. I think it does represent, though, some of the needs of some families, and when we think about these particular conditions, and I sort of have, banged on and on about diagnosis. Well, a good comeback to that is, well, now I'm diagnosed, like, so what?
Yes.
Where is the therapy? So I think actually that question, I'll sort of say, it really represents the future challenge of pediatrics. We will be diagnosing children with serious and conditions. What we need then is to really look to address the challenge of the therapies for them, and we've never been in a position to even address that question before. Now we can sort of say that this is going to be the major focus of research going forward, or we'll be trying to provide these new options. And I think research is key to that, because it means that the cutting edge ideas will be available to children in our region. You won't have to go to Great Ormond Street for it. That's our ambition, but we do need the hospital to give us the capacity to be able to offer that.
Thanks. Probably the last question is, and it seems quite a simple one, but what's the most exciting thing for you personally about the new hospital?
There's so much exciting about it, because I'm really excited by new ideas. I've been practicing pediatrics for 30 years, and I think this hospital is capturing it is the hospital of the future. It's a pediatric hospital that's going to practice almost adult medicine. It's almost like your GP. We're going to make them less and less relevant because we will have gotten things right, and we can look forward to children that have a healthier life course. As a pediatrician, I think that's the ultimate goal, and now we have a strategy to be able to achieve that. So that's exciting. I'm also excited to work with the excellent clinical colleagues at Addenbrooke's. There are 80 consultant pediatricians. There's tremendous passion. The nursing staff is fantastic. Psychology, all of the allied health professionals, even the janitors, it's like it's a wonderful team here. And now the fact that we can make it better and we can provide for our patients better, is also very exciting. So I'm honored to be part of this project, and I really hope we can deliver on the vision for the region.
That's great. Thank you, David. And thank you all for joining us online. And unfortunately, that's our time up. And obviously, a special thanks to David for giving up your time today. So just want to say thanks again for watching. Take care.